Welcome everybody, welcome back. Great to have you here. My name's Matt Egan, I'm from the London School of Hygiene and Tropical Medicine, and this is another of our Viewpoint sessions. We had one yesterday, this is today's. This one's on how can we maximise the benefit of existing UK data sources to improve public health. And we're very pleased and grateful to have two great speakers with us today. One is Professor Andrew Morris, Vice Principal of Data Science at the University of Edinburgh. And since 2017, Andrew's been the inaugural Director of Health Data Research UK, which is the UK Institute for Health and Biomedical Informatics Research, and its purpose is to capitalise on the UK's data resources and research strengths to transform people's lives. And then he'll speak for 10 minutes, and then Ben Goldacre will join us. Ben's a doctor, researcher, and an author. He runs the data lab at the University of Oxford, building tools and services from large health data sets, and advises governments on better use of data and technology. And of course, Ben is well known for helping make science more accessible to a wider public. That being the case, let's have a see. Yeah, it's time for Andrew. I'll just introduce Andrew. And your slides.
How's that?
Yeah, that's right. Great, thank you.
Matt. Pleasure to be here. Great to be doing a double act with Ben. So our exam question is, how can we maximise the benefit of existing UK data sources to improve public health? And I'll canter through this. I'm going to try and convince you that I'm going to talk about infrastructure. We need a good research data infrastructure and a good governance infrastructure if we're going to run studies on up to 66 million people for public health. I'm going to suggest the time is right to harness data science and open science as the catalyst for change. And lastly, talk about trust. With big data and use of the big data sets goes big responsibilities. I just want to tell you briefly around our approach in HDR UK. Our mission is to unite the UK's health data to enable discoveries that improve people's lives. And our vision is that the fourth industrial revolution is going to completely transform medicine, the way we practice medicine, and that large-scale data and advanced analytics will benefit every patient interaction, clinical trial, biomedical discovery, and enhance public health. So for those of you who don't know us, 10 funders got together 3 years ago and funded a institutionally agnostic national institute. We usually sit in the Wellcome Trust, not today, but our job is to look at the platforms, the standards, the interoperability, the policies, and the governance that develops and maintains the integrity of a UK health data research ecosystem that can access multidimensional data. So that's our vision in a slide. It's about diverse data, not just data in the NHS, data in all its forms. It's about scale to 66 million people, but it's about that lifetime perspective, resonating with public health. To do that, we do three things. We unite health data, we improve health data, and we use health data with programmatic exemplars. And this has to be done in collaboration. This is not about a single institution or even sector doing this alone. And that just shows you our sites and our partners and our leadership across the UK. We have 86 organizations across 32 locations. So key to this is partnership working. So in the early days with Sarah Wilkinson at NHS Digital, we established the Health Data Research Alliance, which now has over 52 members across NHS, academia, philanthropic sector, and private sector. And key to becoming a member of the Alliance is that you subscribe to open working methods for health data science research in terms of data standards and quality, in terms of supporting innovation and ensuring your data are fair on a single gateway or shop window, improving participation and access. So for example, we're piloting a single access request form across multiple data controllers, and importantly, engaging the public in everything we do. Key to this is trusted research environments, less data travel. And I'm sure Ben will touch upon this. How do we ensure that safe people work on safe projects, safe settings, safe data, and safe outputs so that we demonstrate trustworthiness in how we as privileged users of data are using it in a trustworthy way. As we know, data quality is a big issue. So 18 months ago, we launched 7 hubs to curate data to a higher quality so it's research grade across a range of disciplines such as respiratory disease, inflammatory bowel disease, and clinical trials. And although young, these hubs are beginning to demonstrate the utility of well-curated data to a broad user base in terms of data sets being enabled for research, plus the number of contracts with academia, NHS, industry using data in a trustworthy way. And lastly, we were asked by the UK government to produce a single shop window so that data sets can be discoverable, a so-called gateway. This again was initially an MVP. It grows, it iterates, but currently we have about 640 data sets discoverable, about 1,000 registered users, and about, this is slightly out of about 15,000 users or searchers in the last 12 months globally. So it's a gateway to see what the UK assets are. And as I said, we're trying to streamline the access to make it really user friendly so that folk know who's got the data, how do they access it for research. So in the last 5 minutes, I just want to give you a case study of how we've taken this approach to a collaborative data infrastructure plus governance infrastructure in terms of the pivot towards COVID-19. In April of last year, we were invited by SAGE to report, well, initially weekly, now fortnightly, to SAGE on how health data research has enabled the pandemic response. And this has been a real collaboration across the 4 nations, as illustrated by the logos. And this has every 2 weeks been put into the public domain. This is a busy slide, but basically what we try to do is highlight all research that has been enabled by health data in the UK across important pillars of surveillance and epidemiology, immunology, longitudinal health, transmission, environment, and trials. But importantly, we've worked in partnership with trusted research environments at ONS, at NHS Digital, in Scotland, Wales, and Northern Ireland to try to bring to the fore what data are available and how can you access them. So this is a very rich tapestry of data sets which are linkable within these TREs. And we also produce a snapshot of how many projects are being worked upon in those environments. So currently 337 projects being accessed by 900 researchers. And it'd be great if the public health community access these TREs. And just to say, under the leadership of Patrick Vallance, we've established national core studies in those key domains that we feel will be essential for the next phase of pandemic response. But there's a cross-cutting theme so that we join it up. So the whole is the greater than the sum of the parts. So we address silos and fragmentation that often conspires against us. So very quickly, some nationwide research outputs. So in the NHS Digital TRE, convened by Kathy Sudlow and Nilesh Samani from the BHF, we now have the ability to access 54 million people with 95% complete data on certain attributes and the ability to link those data across primary and secondary care. This is spanning to the 4 nations. There are now 4 billion records on 56 million patients, and an early output was to show the impact of COVID on non-COVID related harm. The illustration was on the catastrophic reduction in admissions and attendance for myocardial infarction. In the ONS TRE, Ian Diamond and colleagues, the COVID infection survey. As you know, 25,000 households are sampled every fortnight. And not only has it shown us the pace of the pandemic, but it's allowed us to get a handle on long COVID. And also post-discharge, what happens to people. And as you can see, 12% die post-discharge 28 days, 30% are readmitted up to 140 days post-discharge. In terms of the Welsh TRE at Sale, Ronan and David have really at the forerunners of total population data linkage. And that has looked at multidimensional data, including educational data sets, surgical activity in terms of how we use data as infrastructure to drive pandemic response. In the Scottish TRE, Aziz Sheikh and colleagues through the EVE2 and Breathe Hub were the first to demonstrate effectiveness of single-dose BioNTech, Pfizer and AZ vaccination, published in the Lancet 2 weeks ago, showing that there was an 85% sustained benefit of the first dose of Pfizer, 94% of the Chadox vaccine at 28 days. And they're publishing data this week on waning vaccination. Clinical trials, which was the data linkage, was supported by the DigiTrials Hub, as illustrated here. And as you know, the recovery trial, well known globally for the beneficial effects across the UK in terms of recruitment, data linkage to demonstrate the benefits of dexamethasone. Just to emphasize, we're currently looking at other data sets, such as genomic data sets with Sharon Peacock, and again, how that has worked across the UK. So we are now in the process of bringing this into the TREs to enable linkage to this other data as infrastructure data items. And this illustrates the achievements of COG UK. And lastly, this is a forerunner to give Ben a billing. Open Safely has been an outstanding development in the last 12 months and is another national TRE that we're working in the context of the National Core Studies. And here's one illustration of the Open Safely collaborative. And my suggestion is that this is a global pandemic. We need to do this internationally. So working with the Gates Foundation, we're taking the same principles of a trustworthy data ecosystem and looking to build out the ability to share data in a trustworthy way with public engagement in TREs internationally. So to reflect, I would argue the time is now to build out trustworthy national public health data ecosystems. Infrastructure is important. This is about coordination and connectivity, not command and control. We need to demonstrate trustworthiness in everything we do. That's why TREs are important. This is a multidisciplinary endeavor. It is a great exemplar of team science, but most importantly, can we be at the vanguard of advanced open sciences internationally? And I would suggest the new Einsteins will be the scientists who share. And finally, a couple of dates for your diary. We're working with Patrick Vallance on the 24th of June with Jeremy Farrar and many other colleagues presenting, and on the 23rd of June with Marie Van Kerkhoff from the WHO, who is fronting a scientific conference. So I'll finish there. Thank you for your attention, and over to my good friend, Ben.
Hey, thanks all. Kind of you to invite me, and it's great to be amongst public health people. I'm married to a public health consultant. I'm the son of a public health consultant, and I very nearly did public health myself. I was asked to talk about future potential and challenges that remain to be conquered around greater data linkage across, in particular, non-NHS sources like traffic and green spaces, whilst maintaining security and confidentiality. Now, I'll take it as read that you all understand about sort of traditional work with data sets like CPRD, the GP research data set, HERS, ONS death, and so on. And I think more interesting is some of the new work that's been done during the COVID pandemic, when something actually very interesting has happened. There are always huge barriers to working with data, and we've documented those in my team at the Data Lab over the past few years. And typically they fall into three categories: the technical barriers, the regulatory barriers, and the organizational barriers. And what's interesting during COVID, I think, is that under the COPE notice signed by Secretary of State, the regulatory barriers have been very largely eradicated. And so there's been a beautiful natural experiment where we can see what happens if we are no longer obstructed by the regulatory barriers that have held us back. And I think that has really been very telling over time. It's shown that there are some organizations, and in particular some approaches, that are successful, and some that struggle for some quite deep-rooted technical reasons, and also organizational and operational reasons. I'd like to run through briefly what we've built with Open Safely as an example of what you can do with very large data sets, but also the power of, first of all, modern, open, collaborative computational data science, moving away from point-and-click analytics, but also moving away from the unsafe, old-fashioned paradigm of disseminating data out to lots of different places. But it's also a really interesting example, I think, of the power of team science, of the need to bring together skills from lots and lots of different domains. So what is Open Safely? Working on behalf of NHS England, we've now built a full, highly secure analytics platform that's running across the full pseudonymized primary care records of 58 million patients. That's over 95% of the population of England. Open Safely is now the largest national trusted research environment for NHS data in the country. And this is a huge collaboration across my group, the Data Lab at the University of Oxford, where we're a slightly peculiar bunch in the sense that we are a truly mixed team of traditional academic researchers, but also full stack commercial grade software developers. And we turn large data sets not just into traditional academic papers, but also live interactive data-driven tools and services like openprescribing.net, which has 160,000 users a year, where you can see who's prescribing what in primary care, like the Trials Tracker service, where you can see who is and isn't reporting their clinical trials. So we've got an established team of people who know not just about how to do traditional epidemiology tasks, but also how to work with flexible software engineering tools like GitHub, Docker, Python, and so on. We're also working in very close collaboration with the Electronic Health Records Research Group at London School of Hygiene and Tropical Medicine, who've got very, very deep, long-standing knowledge on how to work with very complex GP data in particular. Now, that's complex data. It's really tricky to work with. It wasn't created for research. It's an aid memoir. It's a practical set of structured codes to help doctors and patients manage care together. And when we want to use it for research, we have to process it very thoughtfully. For example, there are lots of people who are children who clearly have asthma because they get lots of blue and brown inhalers, but they've never had a diagnostic code for asthma. So then you have to think, well, I'm going to have to infer that. I'll look at everybody who's had a blue and brown inhaler for asthma on many occasions over the past year, and I'll say they've probably got childhood asthma. Now that poses some real problems. You've got to write the code list. You've got to think about the logic. You've also got to think then about the sensitivity and specificity of that characterization, because you're going to accidentally include maybe some children who've had chemical injuries to the lung. So you have to do a huge amount of data management work with working primary care records in order to get to the point where your data is even ready to begin for you to think about how to do your beautiful mixed effects logistic regression or survival model. We're also working very closely with the electronic health record system vendors themselves, TPP and EMIS, who've given pro bono collaboration during COVID, and they have been absolute heroes. And that brings not just their data environments, because we've built Open Safely inside their data centers, as we'll discuss, but also it brings close collaboration and access to their expertise. And then lastly, we've been working in close collaboration with NHSX and NHS England as data controllers to be fully COPE compliant. So in Open Safely, we've got every individual's full primary care GP record. That's every diagnosis, test, referral, prescription, and so on. That's about 100 billion rows of data in total for the whole country. Then we've got all of that linked onto their data from SUS, so hospital admissions, outpatient visits, coded A&E attendances, CPNS, death in hospital from COVID, SGSS COVID test results, ONS cause of death in and out of hospital, household data. We've got the ONS COVID infection survey just landing right now, the ICNARC ITU data, the ISARIC detailed hospital records of hospitalized COVID patients, which have just arrived. We've got some data on which variant people have, so we can look at vaccine escape and case fatality rates in different variants of the COVID virus. And all of this data flows with unprecedented speed for a full electronic health record data science platform, flows within days of the clinical event. And despite this unprecedented scale, privacy advocates like MedConfidential have actively praised our privacy model. And that's because we've built our platform from the ground up to be highly secure, to protect patient privacy, whilst also being transparent about everything that's done to the data. And that's because of two key and quite important, very technical moves. Number one, to preserve patients' privacy, we don't extract data. We don't let users download data onto their own machine. Instead, we take the analytics to the place where the data already resides. We've built our analytics platforms inside the data centers of EMIS and TPP, where the NHS patient records currently reside. Now, that's really important because of the privacy risks around working with this data. People often say that if you remove the name, address, date of birth of a record and replace it with a pseudonymous identifier, then it is then somehow pseudonymized, not re-identifiable. But that's simply not true. I can re-identify in probably the HES records alone, let alone the GP records. I could easily re-identify Tony Blair. I know the year in which he was born. I know the weeks in which he had his abnormal heart rhythm reset when he was Prime Minister. And from those three facts about Tony Blair, I can be certain that there's only going to be one person who meets those characteristics. And having found the one row for Tony Blair, I can then see everything else about his health record, including things that he may not want me to know. I could look and see if he's had an STD after he got married. I could look and see if he had nocturnal enuresis as a teenager. Patients' records are private, they are secret, and we must respect that privacy. We must take every possible step that we can to prevent that data from being re-identifiable. And that's why data dissemination, I think, should be regarded as an absolutely unacceptable last resort, only to be pursued in exceptional circumstances. So we take the analytics to the data, and so far that's a normal trusted research environment. But we also do more than that. We don't let users even view the data when they work in the trusted research environment. Instead, we've produced bespoke privacy-preserving software, a series of open source tools that enable researchers to use flexible, pragmatic, but standardized approaches to processing the raw electronic health record data into research-ready datasets, and then check for themselves that that's been done correctly without needing to access or view the patient data directly. So using that data management framework, we also generate bespoke dummy data sets. And those dummy data sets are used by researchers to develop their analysis code entirely in the open using GitHub. And only when their data management and data analysis scripts are capable of running to completion and passing all tests in the Open Safely framework, do they finally get to press a button, and those data management and data analysis scripts are then sent through to be executed against the real data inside the secure environment using the Open Safely jobs runner, inside a container using something called Docker, but the researcher never goes anywhere near that disclosive data. And then the non-disclosive summary results, the output tables, the graphs, the logs, are then manually reviewed as in other systems before release. Now, this new and highly secure approach that's been afforded by the software that we built together has meant that NHS England, the data controller, has been able to provide access cautiously to a truly unprecedented scale of data for COVID-19 analyses. It does mean that new users currently need strong computational data science skills beyond those needed to write statistical analysis scripts in a traditional tool like R or Stata. But it also means our approach also means that every analysis executed on Open Safely automatically contributes to a growing library of reusable code lists, variables, and code, rather than unpredictable folders of arbitrary data management and analysis scripts in Python and R and SQL. And lastly, it allows us to efficiently address important strategic and analytic challenges like minimally disclosive linkage and also federated analytics, which is what we're proud of most right now. We've got Open Safely TPP working against 23 million patient records. We've got Open Safely EMIS running against 35 million records. And for the analyses that we've published most recently on 58 million patient records, if you go and look on Twitter today, you'll see a great long thread from some of our long. You write one in Open Safely, press the button, it gets sent off. One to Open Safely TPP, one to Open Safely EMIS. These are completely different computational environments, completely different underlying data schema, completely different data dictionaries, completely different underlying platforms. You write one single code base, it goes out to each, it gets executed separately at each. You produce the outputs, you check they're not disclosive, and then they're automatically stitched back together. And that is a phenomenal achievement by a huge team. Lastly, all the project is open source, all code for the platform, shared openly for security review, scientific review, and efficient reuse by other researchers. All code and code lists shared by default and have to be shared under open licenses for reuse. That's the only way that you can execute code on Open Safely. So what do we use all of this for? Well, we've got papers in Nature, Lancet, BMJ, and more. We're not the only ones who use it. We've got a pilot program for external users. We've got about 8 other external university teams in there now. But crucially, we've also got NHSX and NHS England analysts in there doing operational research, looking at variation in care, looking at service restoration during and after the peaks of the COVID pandemic during 2020. So, as ever, what are the lessons? Number one, this is a testament to the power of teamwork. You can't do any of this just by being an expert epidemiologist, or an expert software developer, or a great clinician, or a great clinical informatician, or an EHR expert. Nobody can be all of those things. So you need tight, fluent teams who combine all of these. This is really, really challenging. Secondly, it's about the power of open. Open science isn't just about the quality gains that come from being able to review each other's code. It's also about efficiency. It's about reusable code, kicking the tires, instead of people endlessly reduplicating their work in a very inefficient way, which is what we're seeing at the moment. It's also about making...
Can we tie up soon? We need to tie up.
All right. It's also about making work dependable. So when we identify problems in the analyses, then we also send through the same digital phenotypes to the vendors. But hey, I'll stop there. Cheers.
Thank you, Ben. We might need to extend this a little bit for the Q&A. I think that should be all right. I've got some questions that are coming up, and one of the strands that came up was around the fact that a lot of the data that seemed to be being described was very sort of biomedical data. Obviously, we're a public health audience, and obviously COVID is one of the things that's shown the importance of social determinants of health environment, commercial determinants, housing, lots of different things. So is data, what about that kind of data? Are we talking about that too?
So do you want to kick off, Ben, and then I'll follow up?
Yeah, so I think all of those other data sources are really important. People don't exist in isolation just with their medical problems. They live in context. I've been a psychiatrist on and off, working clinically since 2000, and there's absolutely no question that the medical does not exist in isolation of the social context. I think the real challenge there is how we can get teams with expertise in the social and the medical working closely together. And I think that goes beyond meetings. I think the way to get people to collaborate is to have the kind of flexible, open technical platforms that capture their expertise in reusable code, in reusable techniques. And that's how we get the true productivity gains that we need to see for health data science, but also data science more broadly across the UK. And I think ONS have really led the field here. During the COVID-19 pandemic, there are really 2 TREs in England that have shipped results. Open Safely is one, but ONS Shared Research Service is the other. I think they've really kicked it out of the park, to be honest. And that's partly down to their emphasis on modern, open, collaborative, computational data science, where they've got a really strong heritage in the social sciences and in government work. So their ONS data science campus is fantastic. Open code, open courses, open training, an emphasis on reproducible analytic pipelines. And I think it would be great to see more of that for health data research in the UK.
Yeah, and just to echo that, I think one of the good things to come out of COVID.
Very poor here. Could people who aren't speaking, including me when I start speaking, turn off and then. So there's a couple of questions about HDR UK. One is about how easy it is for smaller teams, including PhD students, to access the data, because it's the kind of thing that needs to have a large team. Is there training for early career researchers on using the data? And also the question about the public involvement, how much influence does the public involvement have over it?
So the sound quality isn't great. I think the first question was around PhD students. Is that right? Yeah. Did you hear that, Ben? Because I can hear you clearly. I can't hear Matt. Oh, he's gone.
I was asking about training and capacity building and access to some of the HDR resources.
Yeah. So what we saw in the pandemic, actually, because we have our an in-house PhD program funded by Wellcome, and we run it jointly with the Turing. And actually, some of the best research and best outputs was giving this PhD cohort access to the data sets across the trusted research environments at NHS Digital Scotland and Wales. So that that has been a very much a positive from the pandemic. What we're trying to do here is create a level playing field and a low barrier to access to all researchers wherever they are. So we're very keen that career grade researchers all have equal access to these data. And one of the good things about presenting today is to promote the availability of these data sets, because we want to see as many users as possible. And it should provide a fertile training ground for PhD students across the UK, a low barrier to entry. And I think his second question was about public engagement and participation. As we come through the pandemic, I think we will need to demonstrate trustworthiness in how data are being used. And to quote Baroness Honora O'Neill, to be trustworthy, you need to be honest, reliable, and competent. So from really day one, we have been working with the publics, not only in terms of communication of how data are being used in a transparent way, but actually co-creation. So a good example of that was we worked through the National Course Studies with NHS Digital on the Principal trial, which is led by Chris Butler out of Oxford, to create a workflow that connected antigen testing from the Pillar 1 testing regimen through to invitation to participate in a clinical trial in a community within 24 hours. And the public actually helped us design that workflow that accelerated recruitment to the trial from about 700 people to over 4,500 people. So I think that public engagement isn't not just the right thing to do, it also makes the research better. So we're absolutely committed to public engagement.